Thank you very much, Mr. and Mrs. Chairpersons, and thank you for staying here until this hour. I'd like to start by thanking the invitation, the Scientific Committee, for their invitation to be here. It's my first time in Lebanon, and it's certainly a great pleasure and a privilege for me to be here amongst you in your beautiful city of Beirut. I'm going to be talking about recent advances in interparcel monitoring, and I think there have been a few, but I will start by a disclaimer. I don't receive any personal funding from any of the interparcel monitoring technologies that I'm going to be talking to you about, but the university for which I work does receive royalties for one of the systems called the Omniview Sporso system, and they are totally reinvested in research. So I'm going to be talking about three aspects of recent advances. Advances in signal acquisition, advances in tracing visualization, and advances in tracing interpretation. And starting with the signal acquisition, I'm sure many of you will be aware of some of the TOCO monitors in one of the companies. The Philips healthcare monitors have incorporated continuous maternal heart rate monitoring. I think this is a definite advance because it is possible to have a continuous monitoring of the maternal heart rate, as you can see here, together with the fetal heart rate. And as you know, many of the medical legal issues in interparcel monitoring have to do with cases that where we think we are monitoring the fetus, we are in fact monitoring the mother. And we're thinking the fetus is doing okay and he or she is not. What the probe has is a pulse oximetry system that samples the maternal heart rate at once every second, and it does average, so we don't have quite as accurate signals as we have with maternal ECG, but they are more than enough for what we need in terms of obstetrics. Now, I'll be talking to you a little bit about the revised FIGO guidelines for interparcel monitoring later on. They are expected to come out in 2015, but just a quick preview of what it says about continuous maternal heart rate monitoring. This is a consensus statement, and it says that if availability is there and it doesn't cause discomfort to the patient, as it will not do with the TOCO usually, it should be considered, particularly in the second stage, when there are accelerations coinciding with contractions and or the maternal heart rate is elevated, because these are the situations in which maternal and fetal heart rate ambiguities are most frequent. The other advance in signal acquisition has to do with trans-abdominal fetal ECG and also with electrohysterography. So that's trans-abdominal monitoring of the fetal ECG with these sensors that you can see here in the abdomen, and also monitoring of the electric activity of the uterus with similar sensors. And this has been commercialized by a company in the United Kingdom. It's called Monica. And to give you some idea on the studies that have been carried out, first with trans-abdominal fetal ECG. As you probably know, this has been tried for many, many years, but the new algorithms that computers make available have improved the signal quality, and that is, in my opinion, the most important aspect, because if you don't get good signal quality, then it's difficult to interpret the tracings. The studies have shown that similar signal loss is now possible with fetal ECG and with Doppler, at least during the first stage of labor. But I will show you in a minute, I will show you that this is a high signal loss, because in the studies that were evaluated, the signal loss with Doppler is, I think, higher than I was expecting. Another advantage is that you can get also continuous maternal heart rate from the same electrodes, and this leads to improvement with detection of maternal heart rate, fetal heart rate ambiguities. So looking at the studies that have looked at signal loss and the percentage of signal loss, here more than 20% signal loss. This is considerable signal loss. You'll probably notice it visually if you have more than 20%. And as you can see, first stage 21% with fetal ECG, 23% with Doppler, a little bit more than expected, and second stage 53-48. So they are not different, but they are high signal losses. So 53%, more than half of the tracings with 20% signal loss, I think is quite high. And there's also the issue of mobility. This technology was commercialized with the idea that it would allow pregnant women to move during labor and even during the second stage. But from our experience with the similar technology, mobility strongly affects signal quality. So I don't think it will be possible, at least for the short future, to have women moving around and still having good signal quality with this methodology. On the other hand, electrohysterography, on the detection of electric signals from the uterus, this has been consistently shown to have better signal quality than we have with TOCO. Electrodes are very similar, and as you can see, compared with what we consider the gold standard for uterine contractions, which is intrauterine pressure, 97% agreement with electrohysterography versus 61% agreement with TOCO. So I think here we have a definite advantage of this new technology. It's just because it's a different company from those that commercialize the majority of fetal monitors. This has not been introduced into the usual fetal monitors that we have from the big companies. Advances in CCG display. As I'm sure many of you are aware, central fetal monitoring has become very widespread in the industrialized world. And this means simultaneous display of multiple tracings on the same computer screen, and again in multiple locations within the hospital and sometimes outside the hospital, which is technically possible. And the rationale is that you have increased probability of CTG events being seen, of course. Now, we've looked at central fetal monitoring stations in an article that we published at the end of last year in the Journal of Perinatal Medicine. And there are, at the moment, 10 different central fetal monitoring stations that are commercialized, and some of them have some scientific evidence behind them. There's the Guardian system from Plymouth in the United Kingdom, one from Sweden, one from the Netherlands called Moses, Nexus from Germany. They're all pretty similar, but have a few different characteristics. There's OB TraceView from Philips Healthcare, Obix from USA, and our own system from Porto, the Omnivisis Porto. I'll be talking a little bit more about that. And Pericom, which is a US company. And two more. Sorry, this is the slides have not changed. Oh, here it is. So the Sonicade from the UK and Trium from GE Healthcare in the United States. And if you want to learn a little bit more about it, this is our publication in the Journal of Perinatal Medicine. I don't have time to go into detail about the characteristics of the systems, but they have been criticized on one way because, in one aspect, because they constitute a large investment. They are something like $20,000, $30,000. And they do have the potential for people to spend less time with patients because it's more comfortable to be sitting in your room and then seeing it on the computer screen. But it's obviously what we do with it. It's not the technology itself that's at fault. It's the way we deal with it. That's the main fault. But there are several definite advantages of central fetal monitoring because it's much easier to have long-term storage, and it's much easier to have data retrieval. They do promote the creation of large research databases that can be exchanged from place to place. They are very useful for clinical audits and teaching, and we have shown that they do reduce costs with CTG paper. Well, CTG paper, as you know, is expensive. It's thermal paper. So in the long run, you do have some savings by using the central fetal monitoring, where you either don't print the tracings or you print it on normal A4 paper, which is much cheaper than CTG paper. Most of them have an electronic partogram. Most of them have included maternal vital signs. And most of them also have ST data, that's data from fetal electrocardiography. And some of them have computer analysis of CTG and alerts, which is what I'm going to talk to you about now. computer analysis and alerts. Now this is developed because of several human factors that affect intrapartum monitoring. It's not just the technology, it's what we do with it, and there are some, it's possible that some staff are unfamiliar with the guidelines because they have not read it, or they've forgotten about it, or they think it's too complex to understand, and that does happen. Sometimes nobody is looking at the CTG. Sometimes staff are just too busy in working with other problems to look at the CTG, or they're too tired to see the changes. And it's suggested that some people are incapable of pattern recognition or have difficulty with pattern recognition. We're not all the same in terms of the way we can recognize certain patterns, so it's possible that some people do not identify it as well as others. And also there's a lot of disagreement on how to interpret the CTG. It's well known to have a poor inter-observer agreement, and some people have problems in taking action. They hesitate. So really what computer analysis is when it's incorporated with alerts, is prompting healthcare professionals to look again at the tracing, interpret it, and help them take action if this is needed. There are 5 of the central monitoring stations that have incorporated computer analysis and alerts. One of them is the OB TraceView that was developed by Lawrence Devo in the United States about 10 years ago, and it's incorporated into the Philips. There's the Trium, which is bought by GE Healthcare, but it's a group from Germany who has developed the algorithms. There's Pericam, group from Canada, Emily Hamilton, and it's commercialized in the United States. And the Infant, which is developed by Keith Green in Plymouth and also commercialized by a company in Plymouth called K2 Medical Systems. And the last one is the one that we have developed. It's Omniview also developed in Porto and commercialized by a company in Lisbon. It started being developed in 1987, and imagine how long ago that was. And it's been developed and redeveloped, and in 2006 we finally had a commercial version on the market. What is computer analysis? Basically, it is the use of complex mathematical algorithms to look at signal processing. So you use algorithms to determine where the fetal heart rate baseline is, which is this dashed green line here at the top. Maybe you can see it a little bit there. And then you have other algorithms, once you've established the baseline, to identify accelerations, here in green, under the baseline. Algorithms to identify decelerations, here in red, over the baseline. Looks then at long-term variability, short-term variability here. And then looks at contractions, another algorithm to detect contractions, and puts all of this information together to every minute have a real-time analysis and come out with an alert. Now this alert here says prolonged deceleration with reduced variability, so it's this deceleration here at the end with the reduced variability within the deceleration, and we're looking at that, and it's a red alert, meaning it's a pathologic tracing. It also says large signal loss here, because at the end you can see there's quite a lot of signal loss. Just to show you some other examples of alerts. This is the tachycardia. It's the yellow alert, so it means it's just a suspicious tracing. It should prompt some action, but not necessarily to do with hypoxia. So it's just because the baseline has gone above the 160, but there are still accelerations. There are a couple of decelerations that are short-lasting. Variability is normal, so it's just suspicious. Maybe it should prompt people to evaluate the maternal temperature, etc. Another yellow alert, which is the repetitive decelerations here, still associated with accelerations, with good variability. They are short-lasting decelerations, probably typical variable decelerations, so it's just suspicious, it's not pathological. And again, we have here the ST data, so data from fetal ECG saying there is no additional stress on the heart. Very different from this repetitive deceleration tracing, where variability is reduced, there are no accelerations, and they are very suggestive of late decelerations because they have a U shape rather than a V shape. So it says repetitive decelerations and reduce variability within the decelerations. The system is also, I think, useful to identify some rare patterns that people don't come across very often, which is sinusoidal pattern. Here is another example. As you know, sinusoidal is associated with fetal anemia mostly. Another example, the saltatory pattern, quite a rare pattern associated with initial states of fetal hypoxia, acidemia. And this, our system is the only one to have incorporated CTG analysis with ECG, with fetal ECG data. So we have combined alerts, and this is an example. Repetitive decelerations here. Here they lose variability, but it doesn't have enough time to give you an alert on the variability. What gives the red alert here is the occurrence of an ST event, because there has been a rise in the TQRS ratio. So this comes out as a repetitive deceleration and ST event. It's a pathologic alert, and it should prompt healthcare professionals to act and change the situation, either stop oxytocin or do acute tocolysis, or if there are no conditions for that, then promote a very quick delivery. How have these systems been analyzed? Most of them have compared systems analysis with that of experts. So they've looked at baseline accelerations, decelerations, etc., to see how that is compared with that of experts. Some of them have done a validity study, have published a validity study, which is looking at how the most serious alerts, usually the red alerts, have identified or not cases of metabolic acidosis or severe acidemia in the umbilical cord pH. And two of these systems have just finished a randomized controlled trial. The two trials that have just finished is the infant study. It's carried out with the infant system. We're talking about around 25 centers in the United Kingdom, and they have recruited something like 42,000 women. They finished late last year, still analyzing the data, and it should come out at the beginning of 2015. The expected date for the results to come out is February 2015. And there's our own study that was promoted by the University of Porto, but it also took place in the United Kingdom, 5 centers in the United Kingdom. A total of 8,000 laboring women were recruited, and we finished, it took 3 years, we finished recruiting in August this year. We're conducting data analysis currently, and we expect again to have at the beginning of the next year the results ready for publishing. So I think very soon we will know if these use of these systems actually makes a difference to the incidence of neonatal outcomes. So as I've shown you, all computer systems for analysis of CTG and alerts have been integrated in central monitoring stations. They use pretty similar color coding of alerts. Most of them have sound alarms. I didn't talk to you about that, but the red alerts usually come up with not only blinking alert, but it's also a sound alert. But none of them have included clinical management recommendations. So they are alert or alarm systems, but they don't tell clinicians what to do. And the infant system actually started by doing that, but it's retreated, and it's now just doing alerts as our system is doing. It's very important to understand that all the algorithms are different. They follow different guidelines, so it's not correct to pool every computer analysis system into the same bag. They're not the same. It's not computer analysis. Very different ways of doing computer analysis. So if they don't do clinical management recommendations, they will still rely on healthcare professionals to take decisions. So it still will be needed to have a good, sound knowledge of physiopathology, good interpretation guidelines, and to follow the guidelines, because these will be necessary for clinicians to look at the tracings. They will be prompted to look at them again, but it's clinicians looking at them again and then deciding what to do. So training will also be still important. And just to finish on the guidelines, I'm sure most of you will be aware that the only international effort to have fetal monitoring guidelines was promoted by FIGA back in 1985. A meeting was held in Zurich in 1985, and it was published later on in the International Journal in 1987. Obviously, these guidelines that were very useful at the time have grown somewhat outdated, and this has led many countries, and I've got a couple of examples here, to publish their own guidelines. I'm sure there are many others. These are the ones that I know of closer to where I live, but many others have had their own guidelines. And it's very confusing, different terminology, different ways of identifying CTG events, different ways of classifying tracings, and different ways of managing the different tracings. So this has led FIGO in 2013, following on the FIGO meeting in Rome in 2013, to promote a revision of the FIGO consensus guidelines for intrapartum fetal monitoring, and I was honored to have been asked to coordinate this initiative. It should finish in 2015. Just to let you know a little bit how this was done, it was FIGO invited a large group of people to be part of the consensus panel. In FIGO, we invited representatives from the FIGO member societies to appoint an expert from each country to be part of the panel, and you'll be happy to learn that, I'm not sure you can see it, but Dr. Fadi Mirza is the Lebanese representative in this group. We have about 35 different representatives from each country, and we also did a literature search to look for 15 additional experts that have published a lot in this area. So 15 additional experts were invited by FIGO, and I think you will recognize some of their names. There's Larry Devo here somewhere, Gerard Visser, Richard Paul. Richard Paul is 94. He's one of the inventors of CTG, together with Edward Hahn back in the 1960s. Barry Schifrin, who was the man who promoted the non-stress test, again, back in the 1970s. And Julian Parra, Philip Stier, Vincenzo Bergella. So we have a very large group. It's 47 people, and some of these people have published a lot in this area. But we've managed to achieve a consensus on the first two chapters. The first one is physiology of fetal oxygenation and the main goals of intrapartum fetal monitoring. The chapter was written by myself and by Professor Arul Kumaran, who is the president of FIGO, I think you recognize. And we have also managed to achieve consensus on the second chapter, which is the most difficult chapter, cardiotocography. And this chapter was written again by myself, but with Catherine Spong, nominated by the American College of Obstetrics and Gynecology, and Edwin Chandra Haran, nominated by the Royal College of Obstetrics and Gynecology. So these two chapters are finished, but obviously we're only going to produce the guidelines when the 4 chapters are ready. And there's an additional chapter that's just being produced at the moment, which is intermittent auscultation, and it's produced by midwives from the International Confederation of Midwives. So we're very close to achieving consensus on that. And there's a final chapter on adjunct technologies such as fetal blood sampling and also other things like fetal ECG, and that's being written by Gerard Visser. So we hope we will have the 4 chapters ready by March 2015. We actually have that deadline because these guidelines will be presented together with the supplement of the International Journal of Obstetrics and Gynecology at the forthcoming FIGO conference in Vancouver in October 2015. So in conclusions, I hope to be able to show you that there have been advances in signal acquisition. I think some of these advances are with less invasive and better quality, not in every aspect, but certainly in terms of the uterine contraction signal. But commercial competition has somewhat limited its use. They are not widely applied in commercial fetal monitors. That central fetal monitoring has been generalized, at least in the industrial world, together with digital partograms, and I think it's a true advance because it makes access to all the information of labor much easier. Computer analysis is definitely there, many systems on the market, and I think we will know very soon whether or not it contributes to improved management and reduction in adverse outcomes. But algorithms are very different, do not pull them all together into the same group. And hopefully the revised FIGO guidelines will be helpful because they will standardize the concepts throughout the world, and they will also include very objective management recommendations. I hope also to have shown you that it's still a long way to go because it's a complex process. There's a lot of information regarding CTG, and there's still a long way to go, and we're only halfway through it. Now I'll leave you with the advertisement for the second European Congress of Interpartum Care that will take place in my hometown of Porto in May 2015. Thank you for your attention.